All right, you guys. Well, this is take number 5,487, I feel like. Still have a cold, so forgive me for that. But this is, again, Chapter 3, Abdomen, from the 11th edition of the textbook of radiographic positioning and related anatomy. And this starts actually on page 102. Excuse me. With an abdomen, it is probably the second most commonly ordered exam behind chest. And they start off this chapter on 102, by talking about the muscles that are actually part of the abdomen. And the three that they mention specifically are the diaphragm, which is a dome-shaped muscle that's used in ventilation, the right and left major psoas muscles. So those three are very important. The diaphragm is especially important because when we give the patient breathing instructions, certain things are attached to the diaphragm, so the movement of the diaphragm allows for either visualization or no visualization of the anatomy. Some of the soft tissue landmarks, you can see that these arrows here are outlining the psoas muscles. So you can see those on a fairly small patient that is well visualized on a diagnostic abdomen. They also go through the digestive tract, and they talk about the digestive tract along with the accessory organs of digestion, which are the liver, the gallbladder, and the pancreas. The spleen is not actually part of the digestive system, but part of the lymphatic system. They list it in here because the spleen is located within the abdomen, though it is not part of the digestive system. The stomach and small intestine, when they point out these on page 103, figure 3.4, you can see that they visualize, or they show you the stomach, which has many parts to it, and then it goes into the small intestine, which has three portions. It has the duodenum, the jejunum, and the ileum, and then you go into the large intestine, or the large colon, and the duodenum is the shortest segment, but it's also the widest portion of the small intestine. It's about 10 inches in length, but it's the widest portion, and as you move on, it gets narrower. So the jejunum makes up 2/5 of the small intestine, and typically the jejunum, the way this is labeled actually is not correct. The jejunum is actually over here. So if you look at figure 3.4, that has it labeled correctly because the jejunum is actually on the left side and the ileum, spelled with an E, is on the right side. So figure 3.4 on page 103 is correct. This picture does not look correct. The jejunum does make up 2/5 of the small intestine, and the ileum, and notice the spelling, it's different from the ileum in your pelvis, which is spelled I-L-I-U-M, but that makes up 3/5 of the small intestine. So shortest segment, widest, gets narrower, and the very narrowest is in the ileum. This is actually a picture. You can see the stomach full of barium. You can actually see the rugae in the stomach, which are the folds that allow for expansion. So you have rugae in the stomach. That is usually seen on a upper GI study, especially if the patient has been NPO or had nothing by mouth for at least 8 hours. This rugae allows for expansion of the stomach, and you also have rugae in the bladder that do the same thing. They allow for expansion. You can see this segment right here is the duodenum, which has like a C shape to it. This is the part that is about 10 inches in length, and it's the widest section. Then we go into this section over here, which is the jejunum that makes up 2/5 of the small intestine. And this section has little microvilli in there that give it kind of that feathery or pillow stuffing appearance. And then from the jejunum, we move into the ileum, which makes up 3/5 of the small intestine. It's also the narrowest section of the small intestine, and then that leads into the ileocecal valve. So it leaves the ileum of the small intestine and goes into the cecum of the large intestine. You can see here the ileocecal valve, and then it goes up the ascending colon, around the right hepatic flexure, across the transverse colon, around the left splenic flexure, down the descending colon, through the sigmoid, rectum, and out the anus. That picture is 3.6 on page 103 and is an excellent diagram to capture all of the anatomy that is in the abdomen of any patient. The only difference would be where things are located based on body habitus. We mentioned the accessory organs of digestion. So the liver is the largest solid organ in the body, and the liver has many functions, but the biggest function that is specific to digestion would be the production of bile. And bile breaks down or emulsifies fats in our diet. And then if you have a gallbladder, the purpose of the gallbladder is to store the bile that's created in the liver. The pancreas releases enzymes that break down starches, and the head of the pancreas is actually nestled in the C-loop of the duodenum. And then they reference the spleen, but again, the spleen is not part of the digestive system. It's actually part of the circulatory system. It's part of the lymphatic system, but it is located in the abdomen, so they do bring reference to it as far as its positioning in the abdomen. These are CT images, which we've talked about in class, the fact that CT images are important to start looking at cross-sectional anatomy. So as mentioned in class, this would be a transverse cut. So imagine you were standing at the foot of the table at the patient's feet, and you bent down and you were looking up from their feet towards their head. And this would be an image if the patient was a loaf of bread. Each slice in the loaf of bread would be represented by one of these CT scans. This is the posterior aspect of the patient, anterior aspect, left side of the patient, right side of the patient. And some of the anatomy that we want to pick up on are these white areas around the periphery. That is your ribs. You can see they've outlined the spleen here. You've got the thoracic vertebrae right here. You've got the liver, which makes up most of the right side. And then they show you the stomach that has contrast in it. As you go down in slices or down in the loaf of bread, you still can see some of the ribs. We can see the spinous vertebrae of lumbar 2. You can still make out the liver. Now the gallbladder comes into view. These are the kidneys right here. And anytime you see round structures, those are typically blood vessels. So in this case, you've got abdominal aorta and inferior vena cava. Now, as far as identifying these structures, it's just a good idea to start looking at them and get a feel for what you actually are seeing on there. Not for testing purposes so much, but the registry is pushing to start making cross-sectional anatomy a part of our registry exam. The urinary system is shown on page 105, figure 3.10. Recognize that this urinary system is all sitting behind all of those other abdominal contents. So in order to do any imaging of the urinary system, you would have to have the patient have a completely cleaned out intestinal tract so that you could visualize this. And the urinary system is composed of typically 2 kidneys, 2 ureters, 1 bladder, and 1 urethra. You've also got the suprarenal or adrenal glands that sit on top of each kidney. And then patients can have multiple kidneys. They can have 3 kidneys, 4 kidneys. They could have 2 ureters, 3 ureters, 4 ureters. Typically, patients only have 1 bladder and 1 urethra. And in order to survive, a patient needs at least 1 kidney because it does act like a filter. And without that filter, the patient would have to undergo dialysis. an intravenous urogram or an IVU. This picture is also on page 105, figure 3.11. This is actually a really good image. You can see you've got left kidney here, right kidney here. These are the calyces that collect the urine, and this right here is the renal pelvis, where the urine comes in and collects, and then peristalsis moves it from the renal pelvis down the ureter into the bladder on both sides. And this picture actually captures that the entire way, and this is the bladder starting to fill with contrast. As far as the anatomic relationships, they are showing you this is a mid-sagittal section of the abdomen. Looking at them from a lateral view, you can see you've got anterior aspect, posterior aspect, and they're showing you the difference between the omentum and the mesentery and the peritoneum. So the peritoneum is actually what covers the organs and the wall. So in the thoracic cavity, we had the pleura. We had visceral pleura and parietal pleura. In the abdomen, we have visceral peritoneum and parietal peritoneum. So visceral peritoneum actually lines the organ itself, and the parietal peritoneum lines the wall of the abdominal cavity. So visceral and parietal peritoneum. And then we have the mesentery, and the mesentery is actually a double fold of a peritoneum. So it's a double fold of peritoneum, like a doubled up layer that extends anteriorly from the posterior abdominal wall, and it completely envelops the loop of the small bowel. You can see that they're showing you how it envelops the small bowel here, and it basically keeps the small bowel from moving all over the place. It's kind of interesting when you think about it, how we can jump, run, move, do a cartwheel, do all kinds of things, and our organs aren't flying all over the place, which doesn't really make sense that it works like that. But the mesentery and the peritoneum, the mesentery, the omentum all hold that in place. This is a picture of the greater omentum, and this is on page 106, figure 3.15. So the omentum is actually also a double fold of peritoneum that extends from the stomach to another organ. And the lesser omentum goes superiorly from the lesser curvature of the stomach to portions of the liver. And they usually reference this like a fatty drape. It kind of does look like a curtain. It's like a curtain of fat. And then they draw it up over the chest, and you can see the transverse colon there, and then all of the small intestine. So the greater omentum and the lesser omentum are double folds of peritoneum that go from the stomach to another organ. The mesentery is a double fold of peritoneum that goes around the small intestine, and then the visceral and parietal peritoneum are what actually lines the abdominal cavity and the abdominal organs. This is that sagittal section of the abdominal cavity. This is actually on page 107, figure 3.16, and they're showing you how the different organs lie, whether they lie in the peritoneum, behind the peritoneum, or below the peritoneum. So infraperitoneal means they lie below the peritoneum. Intraperitoneal are the organs that are within the abdominal cavity, such as the liver, the gallbladder, the spleen, the stomach, the jejunum, the ileum, the cecum, the transverse colon, and the sigmoid colon. And then you've got several organs that lie retroperitoneal, and then some that lie below the peritoneum, such as the lower rectum, the urinary bladder, and some of the reproductive organs. This is another picture. This is from 3.17. You can see that these are the retroperitoneal. They lie behind the peritoneum. And then the liver, the gallbladder, all of these are within the peritoneum. So intra means within, but they've kind of removed those, so you're not really visualizing them. And then the infraperitoneal are the ones that lie below. So behind the peritoneum, within the peritoneum, below the peritoneum. And no, I'm not planning on testing you on those. It's just interesting to look at the chart on page 107, table 3.1, to see where everything lies within the abdominal cavity, because it's kind of crazy that with all the different body habitus, all of these structures are within each and every one of us. Next, we have the abdominal quadrants. These are on page 108. Notice that these quadrants always are represented as if you're looking at the patient. So it's simply a way to divide the abdomen into fours so that when patients reference pain or any problems or issues, it's easier for them to point to their abdomen, and we can simply divide that abdomen into fours. And if they're complaining or pointing to pain up here, we could reference they have pain in the right upper quadrant, right lower quadrant, left upper quadrant, or left lower quadrant. So this is what it would look like if you just were dividing a patient in four. And then, like I said, depending on where they complain of pain, you have the capability to convey that to the radiologist much easier than saying, they complain of pain in their descending colon. Some of the topographic landmarks, there are 7 of them listed, and they are on page 109. So these are landmarks that are palpated. These are things that we feel on the body that correlate to areas within the body. The first one they mention is the xiphoid process, which is found at the level of T9, T10, and that is a really good landmark to use for centering. It references midline often. Unless the patient has had open heart surgery, then the sternum is a really good indicator of the patient's midline, and that's represented by number 1. Number 2, both in an AP and a lateral position, this is the inferior costal rib margin, and that correlates to L2, L3, and we use that landmark quite a bit when we do upper GI positioning. Number 3 is the iliac crest, which correlates to the level of L4, L5, and that typically is the very top of the ilium, spelled I-L-I-U-M. So when patients put their hands on their hips, as we typically say, that's where they're actually placing their hands, is on the top of their iliac crest. Number 4, 5, 6, and 7. Number 4 is the ASIS. So these are in the lower abdomen. The ASIS is the anterior superior iliac spine. You can see in the lateral, it's that little protuberance that points out, kind of juts out. If you're laying on your back, you can kind of feel that. That is your ASIS, and that is used quite a bit on pelvic positioning and vertebral structures, but it's also used in abdominal imaging. So that is your ASIS. Number 5 is your greater trochanter, and that is this knob-like projection on the femur. A little bit harder to make out in the lateral, but this is actually what it is right here. So the greater trochanter is typically kind of easily palpated. You typically have to rotate the leg back and forth to feel it, but that tends to line up with the superior crest of the anterior superior crest of the pubic bones, which is the inferior margin of the abdomen. So we use that quite a bit, the greater trochanter and the symphysis pubis in abdominal positioning. The symphysis pubis is actually the junction between the 2 pelvic bones, so it's actually right here, but we use the superior anterior portion of the pubic bone. That's what we palpate when they're supine, and that marks the inferior border of the abdomen. It's a little bit easier to see on an x-ray image versus this image here. And the last landmark that we look at is the ischial tuberosity. It's actually the most inferior portion of the pelvis. It is the area, if you go to a baseball game and you are sitting on the bleachers and the next day your rear end is kind of sore, it's likely because your ischial tuberosities were digging into the bleachers and it is not a comfortable feeling. This next picture kind of shows it a little bit better though. This is your iliac crest. This would represent your ACEs. So this is looking at the patient from an anterior aspect. This would be looking at them laterally. So ACEs, iliac crest, ischial tuberosities are right here. Pubic symphysis is here, but the palpated portion is typically the anterior superior portion of both pubic bones is what we palpate. And then greater trochanter is this knob-like projection. But typically when you're palpating that, you tend to be in line with the pubic arch, and that is what we feel for abdomen positioning because this marks the inferior border of the abdomen. When we look at radiographic positioning of the abdomen, we tend to look at the KUB or an AP supine abdomen. And then there are other positions such as an acute abdominal series, which includes 2 pictures of the abdomen and 1 picture of the chest. And then we also have decubitus positions, which we know implies horizontal beam, and we're looking for air fluid levels. So we do lateral decubitus on the abdomen and dorsal decubitus. As far as patient preparation, this is on page 110. With this exam in the abdomen, basically all clothing has to be removed. Typically that includes top, bottom, underwear. Shoes and socks I would usually leave on the patient until they come into the room, and once they get up on the table, then I would take their shoes and socks off, but prior to that I would leave them on so that they're not walking barefoot on the floor or stepping on anything. I would never let the patient walk barefoot, probably not even in socks, just because you never know what can be on the floor in a hospital or imaging center. It's just a good idea to have their feet covered. Any opaque objects would have to be removed. Any piercings, buttons, zippers, clips, anything that the patient might have that is able to be removed that would be opaque should be removed. And we typically put a gown on with the opening to the back. As far as positioning considerations, we try to make the patient as comfortable as possible. Typically, we give them a pillow under their head. Sometimes you can put a pillow under their knees for support. One of the biggest things with abdomen is really careful breathing instructions. So with chest, we always did the patient on double inspiration, and then they held their breath. And the marker was placed up on the left side. With abdomen, the marker is down and on the left side, but the breathing for an abdomen is actually exhalation. And the reason for that is when the patient exhales, the diaphragm actually rises, which shows you more of the abdominal contents, because the superior border of the abdomen is the diaphragm. The inferior border is the pubic symphysis. So when you have the patient exhale and the diaphragm rises, that actually shows you more of the abdominal contents than if the patient was to take in a breath and hold it. As far as markers, we still tend to use left marker unless it's a left lateral decubitus, and then we would be forced to use right marker. And collimation is absolutely vital. Especially now that shielding has kind of gone by the wayside. The only way we have to help adhere to the ALARA principle is to use appropriate collimation and radiation sparing doses. Gonadal shielding, as far as the registry is concerned, males can be shielded on abdomen because the gonads lie below the pubic bone. The testicles lie below the pubic bone, so shielding is able to be done, but females typically are not shielded on abdomen because of where the ovaries lie. This ovarian shield, which really it's a thyroid shield that they're using, But what they're telling you in this picture is that they're looking mainly at the hip, so they're trying their best to protect the ovaries. But now with the techniques that we use, that should not be an issue. And shielding has pretty much gone away in all the areas that we attend clinical sites, but somewhere else in the country, it might still be a work in progress. The registry does still recognize that shielding should be done. Until everybody agrees, eventually it will be taken off the registry, but that is not current practice. The exposure factors, this comes from page 110. They tell you with analog or digital, with analog, which is film, you were around 70 kVp on an abdomen. With digital, I would tell you, I know this says 80, but I would say it's closer to 85. So I would say it ranges, typically we use 80 to 85 kVp. We try to use a high MA and a short exposure time to reduce motion. And as always, we try to use high kVp, low mass techniques to give a radiation sparing dose. Now, before we get into this, some of the special patient considerations that we have to think about are pediatric patients. Pediatric patients, the biggest factor is probably time and using the shortest exposure time possible. Typically, if a child is under 12, then there's a significant reduction in kVp and mass. Over 12, 13 years of age, they are getting closer to an adult body habitus, and the reduction would not be as significant. Some of our geriatric patients, our elderly patients, one of the biggest concerns with them is probably comfort, and having extra patience to explain things to them and let them know what it is you need from them, what you need them to do and not do. With any patient, I would argue careful breathing instructions is essential so that you don't have motion on your radiograph. And last but not least are bariatric patients. Bariatric patients probably are going to require multiple IRs. Ideally, they're probably going to require 2 IRs placed landscape with overlap, but occasionally you will have a patient that is large enough that they require abdominal quadrant images, meaning 1 IR for each quadrant of the abdomen. These are some of the views that we do for abdomen. Typically, routine abdomens are either 1 AP supine abdomen with the IR placed portrait, 2 crosswise or landscape IRs, typically like your bariatric patient. It could be 4 quadrant images, but that's probably more rare. And then something that some of the sites do is what's called a T-shot, where literally it looks like a T. You have 1 image receptor placed portrait at the bottom, capturing the pubic symphysis and up, and then you have an IR placed landscape at the top to capture the diaphragm with overlap. Some of the special views would be a prone abdomen, a lateral decubitus abdomen, an erect abdomen, or a dorsal decube. So in this video, we're just going to talk about the routine supine abdomen. In another video for later on in the week, we'll talk about these other images. An AP abdomen after our pathologies in the book, this is on page 114. Notice it's called an AP projection because the path of this central ray, represented right here by this pointer, enters the anterior aspect, exits the posterior aspect, and then strikes your image receptor, which is in the bucky, because typically most adult abdomens are greater than 10 centimeters in thickness, and your KVP is above 70 with digital. On this particular image, they are telling you that with this patient, you could do 1 IR placed portrait to the patient, and according to the book, the only required anatomy is an outline of the liver, the spleen, the kidneys, the psoas muscles, the stomach and bowel segments, and the arch of the pubic symphysis for the urinary bladder region. It does not require the diaphragm. According to the registry, an AP supine abdomen does not require the diaphragm because you're not looking for air fluid levels. Okay, this is the only image of the abdomen that is not looking at air fluid levels. With this, you're typically looking for some kind of obstruction, some kind of neoplasm, maybe kidney stones or calcifications in the gallbladder, ascites, which is excess fluid in the peritoneum. And it also is a scout image done for barium studies, meaning this image would be done before the patient gets barium. That way you have an image to compare it to, so that when the patient has barium, you can always go back, the radiologist can always go back and see what their abdomen looked like prior to the barium being ingested. So for this particular picture, notice it's a 40-inch SID. The field size is 14 by 17 portrait. The KVP range, they tell you 70 to 85. And I would tell you that for this particular image on a stenic patient, I would likely use 80 kVp at 10 mass. They show you the patient lies on their back, and the central ray is iliac crest and midline. So this does not require diaphragm according to the registry, but there's always a but, huh? On site, the radiologists feel that if they are going to read an abdomen image, then they want the entire abdomen, which technically goes from pubic symphysis up to diaphragm, meaning the superior border is the diaphragm, the inferior border is the pubic symphysis. So radiologists want to read all of the abdomen if they're going to order a supine abdomen. So according to field, they want the entire abdomen demonstrated, which means you're forced most times on a patient like this. This would be a good example of your T-shot. So you get an image lower to capture the pubic symphysis with a portrait IR, and then you would do another image receptor after this picture placed landscape to capture the diaphragm. Okay? So on this particular one, they're telling you iliac crest and midline, no diaphragm needed. They do make note underneath the respiration, which is done on expiration, that they reference a tall hypostenic patient may require 2 images placed portrait, but that would be an awfully tall person. But the other note references that a hyperstenic patient may require 2 IRs placed landscape, 1 centered low to include the pubic symphysis, and the second for the upper abdomen, and there has to be a minimum of 1 to 2 inches of overlap. The criteria needed on this, the pubic symphysis has to be visible, which is just barely right there. You can see the arch of the superior arch of the pubic bones. The kidneys and the lower liver margin have to be included. So here's the liver and the lower liver margin. One kidney is here, the other kidney is here. No rotation, no motion, and exposure factors should be a sufficient brightness, sufficient contrast, which I would argue that is a pretty good abdomen picture. This is similar to the picture in 3.31 on page 115. A PA abdomen, that is on page 116, not near as common as an AP abdomen because it does make, if the kidneys are the region of interest, it increases OID between the kidneys and the IR compared to the AP. But maybe the patient had back surgery and they're not able to lie on their back, in which case a PA abdomen would be sufficient. The technical factors still at a 40-inch SID, still 1 IR they recommend placed portrait. Technique would be the same, and then the positioning is the same as well. You're at iliac crest and midline, taken on expiration, and this does not require diaphragm. It only requires pubic symphysis, which means that in this particular image and based on the book, they're telling you 1 image receptor. but I am telling you in field on this patient, they would likely do a T-shot, which means this image they would expose, and then they would come back and do an image place landscape to capture the diaphragm. The criteria is the same as far as what you need, but notice the pelvis looks completely different on a PA abdomen versus an AP abdomen. Just completely different look to that, which it's just kind of odd to look at. So a lot of times the radiologists, they don't prefer a PA abdomen. They'd rather have an AP abdomen, but if warranted, then this would be acceptable to do. But like I said, most of the time we're not doing one image. Minimally, we're doing a T-shot, or we're going to do 2 IRs placed landscape with a minimum of 1 to 2 inches of overlap on the patient. Okay, so this is the first part of the abdomen. Hopefully you were able to pay attention and write down any questions you might have. If so, go ahead and bring those to class and we'll discuss them, and we'll look at the T-shot and the 2 crosswise just to make sure everybody's on the same page. So thank you so much, and I will see you soon.